Okay, good evening. Welcome back to our Paediatric Series from Mind the Bleep. My name is Dr. James Mackintosh. I am an SHO currently working at a district general hospital, which for those of you not working in the UK, means it's a much smaller hospital with less specialties. But the good news is that means I get to see both adults and children, and a variety of minors, majors, and all the weird stuff in between. So this evening, what are we doing? So we're going to be doing an introduction to newborn resuscitation. And what to expect tonight. So all I'll be doing is recapping a really good teaching session that I actually received at my new job, which was delivered by one of the paediatric consultants. Now, what this is not is a formal qualification in neonatal or newborn life support. It is not a practical session, obviously, because we're here online, and it is not something that you can be taking away and start running resus calls. But the reason I wanted to give it is because the session that I attended just really highlighted to me, as someone that hadn't done this training in about 2 years, is just how different basic life support and resuscitation is in the newborn compared to adults. So I thought it would just be good to see an overview of all the different steps, just to kind of get you thinking. And if you are lucky enough at work or at your medical school to get some more training on this, you'll just be that much more prepared. Okay, so normally in adults we kind of do our A to E, so airway, breathing and circulation, which you can see do make up some of the steps that we'll be looking at this evening. But we also have to dry them, warm them, do an initial assessment, which again is slightly different. And then we also have to think about which drugs we want to give, but we'll come to that shortly. Okay, so dry, warm, stimulate. So this is not something we normally do with adults, but if we are approaching a newborn, particularly term and near-term infants, so above 32 weeks gestation, what we want to do is dry them off because they will lose heat unbelievably quickly. And there is a lot of good evidence to show that if their temperature is not managed, there are significantly worse outcomes. Or a way that I had it explained to me, which helped me think about it, is the fetus, when it's inside its mother, is kept at 37 degrees. And while our hospitals can feel rather warm during the summer months, coming out into the fresh air, when you're all wet, you're not going to be maintaining that body temperature. So we're going to get some towels. We're going to give them a good dry. We're going to try and vigorously stimulate them, just to get them kind of awake, clearing their own airway, getting rid of some of the fluid in their lungs. Once you dry them with a towel, you get rid of that damp towel, because if you leave a damp towel on them, they're going to stay wet, aren't they? So we wrap up that newborn with a new towel. We keep their head warm with a hat. And yes, I know what you're thinking. Where on earth do I find a baby-sized hat when I'm in the emergency department? So in resus, at least in our hospital and most other resus departments that I've been to, they will have a specific paediatric resuscitation trolley. And in one of those drawers, there should be newborns and neonatal kit. Now, our one has a big drawer. You pull it out. It has these two boxes. One is for term and near-term infants, and it's really clearly labeled on the top. And the other is for preterm infants, because you're going to need slightly different kit for these two different subsets. So like I said, we're going to put a hat on their head, just like when you go out in the winter. You lose a lot of your body heat, as you know, through your head. So we can pop that on, and we can put them on a thermal mattress. Whereas preterm infants, so before 32 weeks gestation, we don't dry them with a towel. We don't worry about all this stuff up here. What we do is we have this special polythene wrap, so kind of like a plastic bag, and we put them in fully wet in a plastic bag that comes up to their neck. And that helps maintain their body temperature, and we can then put them on a thermal mattress and proceed to the next steps. Okay. So, initial assessment. So if we think about if any of you have seen a normal birth or a C-section without any resuscitation, you will know that we do something called an APGAR score. And listed here are several elements of that APGAR score. So the tone, the color, how they're breathing, and their heart rate. And this will form are initial assessments. It's exactly the same in a situation where you think you might be needing to resuscitate this newborn. So if they've got good tone, we're less worried. If they're floppy, there's a good chance that they're not going to be, using their muscles correctly, and we're going to be needing to give them some respiratory support. So we're going to need to ventilate them. Color, we like pink babies. Babies come out, they should be kind of pink. If they're looking a bit blue, a bit pale, we're thinking kind of cyanosis, pallor. So cyanosis if they're blue, meaning they're not getting enough oxygen. Pallor, meaning maybe they don't have enough blood circulating, maybe they've lost some blood during the birth. Again, these are the sorts of things that make us think we're going to need to do some sort of intervention. Breathing, you assess, very similarly to how you would assess an adult. So we look at the rate, we look at how hard they're working. Is their chest moving symmetrically? Is their chest moving at all? These are all things that we look at. And we do so, and we try and, we assess that over 10 seconds like we would in an adult. And then we go on from there. So heart rate. This is, again, one of the big changes between adults and newborns. So heart rate is actually the best determinant of how well a newborn baby is breathing. And I know that sounds strange, when we've just looked at how they're breathing, but if their heart rate is above 100 beats per minute, excellent. Likelihood is they are breathing well, don't need any help, and we can kind of relax. If it's in that 60 to 100 beats per minute range, we do start to worry. We definitely start to think about intervention. And below 60 beats per minute, we at this point would be really, really worried. So if any of these factors that we've just talked about are present, we definitely need to be putting out a cardiac arrest call, and specifically a paediatric cardiac arrest call. So in UK hospitals, you would ask someone to put out a paediatric cardiac arrest call, which you do by dialing 42, so 2222, and you would say, I'm putting out a paediatric cardiac arrest call, give your location, and then the switchboard operators would send that out to everyone holding a paediatric crash bleep. And I'm emphasizing the fact that you say paediatric, because if you just put out a cardiac arrest call, you will get the normal cardiac arrest team, which is good. You normally get some anaesthetists, maybe some medics, maybe some ED doctors. But importantly, you don't get a pediatrician. So you do not get the experts in children and babies. So we've called for some help. And the other thing we can think about is whether to delay cord clamping. Because there is really good evidence if we delay cord clamping after birth for at least 60 seconds, that promotes better outcomes than if we immediately clamp the cord. However, if we have all these worrying features ongoing, we would choose not to delay cord clamping. We would immediately clamp the cord so we can get this baby into resus and we can start to work on them. Airway. Once again, it is different. So we're trying to say, is the airway patent? So in an adult, are they talking? Are there added sounds? If they're kind of snoring, gurgling, that would make us think there is something obstructing that airway. Now, if you look at the image over on the left-hand side of the screen, you can see in a baby, the airway position is actually slightly different. So you want to, when doing your chin lift or your jaw thrust, you want to get it so that their head is horizontal. So the airway is perpendicular, so at a right angle, going up here. I'm not sure if you can see my cursor. That is the correct position. If we lift their head all the way up like we would with an adult, we actually end up overextending and closing off part of the airway. Similarly, if we don't help them, they can end up, with their chin down, and again, that's going to block off their airway. But it's a similar sort of assessment to adults. So if we're hearing those gurgling sounds, those snoring sounds, the chest isn't moving, that is going to be making us think we might need to adjust our position. And if you are in the unfortunate position to be managing that area and you're not feeling very confident, ask for some help. But the other thing is just think, well, okay, I think I've opened the airway, but they're still making some noises to make me think that there's an airway obstruction. Let me check my position. Let me adjust my position. See, does that improve something? Or does it not really have an effect? So, like I said, we're aiming for a neutral position with that airway. If the baby does not have very good tone, so you have a floppy baby, you might be needing to do that jaw lift, which is, again, exactly the same technique with an adult, but obviously it's in a much smaller person, so you just need to slightly adjust your hand position. If you're not really sure what I'm talking about, or you think, well, that kind of doesn't make much sense to me, if you get the opportunity, try and go down to your clinical skills department, go down to your resus department, ask if they have some of the kit and a mannequin that you can practice on. And I've always found they're incredibly helpful, and they like to teach. Is what they do. So typically we would be starting with a mask if we think that they need some ventilation support. This is just a standard face mask. You put it so it covers the nose, the mouth, goes over the chin, but importantly does not press down on that trachea. And it is a specific size for newborns, which you would find in the paediatric trolley. There are other options like the laryngeal mask, oropharyngeal, nasopharyngeal airways, and intubation. So those are kind of things that you can use to escalate. Suction, just like in adults, needs to be done with direct visualization. So you only suction what you can see. What we never, ever, ever do is stick our Yanko sucker just down into an airway that we can't see, because there's a good chance you will push things further down. You might damage something and cause a whole lot more problems than you're solving. But the important thing in suction is you do not delay ventilation. In newborn resuscitation, ventilation is the name of the game. So the most important thing is we start getting that chest moving, get those lungs working, clear out the liquid, and get that baby breathing. Okay, breathing. So look, listen, feel. If the baby is not breathing, if they're gasping, or you just think, you know what, they're not breathing as effectively as I would like them to, rather than diving straight into CPR like we do in adults, we give 5 inflation breaths. And we do that in air typically. We'd be using positive pressure ventilation using a bag valve mask with a 3-second squeeze for a breath in. And you can, again, see if you can get your hands on some kit and just practice counting, 1, 2, 3, 1, 2, 3. And as I said before, the heart rate is a really good indicator of whether or not this newborn is receiving effective ventilation. So if the heart rate is less than 100, something has gone wrong. Either your positioning of the airway is not very good. There's a blockage. There's something wrong with your techniques. You might get a second person in to put their hands around the mask to make sure it's a tight-fitting, airtight seal. And as you can see, I have put in the top left-hand corner a screenshot from the newborn resuscitation algorithm from the Resuscitation Council. So if the chest is not moving and we're doing these inflation breaths, we want to check our mask, check our head and jaw position. As I said, get a second person to come in and make that tight seal so we can focus on just doing the ventilation. Think about, do I need to put in an airway adjunct? Oh, sorry, I've just skipped ahead. We would repeat the inflation breaths. Like I said, it's really important that we start ventilating them. So if we've done some inflation breaths, but it's not worked, we need to try again. And we would also think about increasing the pressure at which we're inflating. And then, like any kind of A to E or resuscitation, we go back and we reassess, see what's going on. Okay? So, if there is a heart rate response to the inflation breaths, excellent. We still need to continue to ventilate them until they're breathing on their own. But we change the rate at which we are ventilating. So, the kind of when we're squeezing the bag, it would be 30 breaths a minute. So 1, 2, 1, 2, 1, 2. And you aim for 30 breaths per minute. And then when you've done that for 30 seconds, you would reassess the heart rate and the breathing. And the whole time, if you're managing that airway, you are looking for that chest rise, you're monitoring the heart rate. You want to make sure what you're doing is effective. Okay. But again, we can only get into that kind of, continuous ventilation if we know that our ventilation is working, going into the lungs and inflating them. Okay, circulation. So, as I said earlier, we would have called for help. We would have, an anaesthetist coming, a paediatrician coming. hopefully you will have someone else here by now. It will not just be you trying to revive this baby. And quite a few of these things, they require several people. There might be 2 of you using that bag valve mask, someone else doing chest compressions, someone else running the ball, people getting bits of kit. It is a team game. So, circulation. So, if the heart rate is not detectable, or it is below that cutoff of 60 beats per minute after our 30 seconds of ventilation, we need to start doing CPR. Now, in adults, we do 30 chest compressions to 2 breaths. In children, we tend to do 15 compressions to 2 breaths. But in the newborn, we would be looking to do 3 chest compressions for every 1 breath. And that's, as I've kind of tried to emphasize to you guys, ventilation is really, really important. So, if at this point that's not working, we're going to give some chest compressions. We're going to continue to ventilate them. We're going to start supplying with them some oxygen. And if we haven't already intubated them, we're going to be considering intubation at this stage. So when we measure the stats, we do it on the right arm, normally the right wrist, or you can go on the right leg, but right wrist is the kind of gold standard, and that's so it's a preductal measurement. And as you can see over on the left-hand side of the screen, we have some acceptable preductal sats. So at 2 minutes, we're not expecting the baby to be doing a fantastic job of breathing on their own. We're just not. They've gone from having fluid-filled lungs into a world full of air. It's kind of unreasonable to expect them to be breathing perfectly at the start. So 65%, and we're happy. At 5 minutes, we're kind of hoping that they're getting it together. It should have come up to 85%. And after 10 minutes, we would hope that their saturations are above 90%. And next to that little table, I have just put in a diagram here of someone giving chest compressions to a baby. So for those of you that have not managed to attend some sort of neonatal or newborn resuscitation course, what we do is we put our thumbs on the zippy sternum, hands wrapped around the back, as is seen here, and we push in, giving those 3-to-1 compressions to ventilations. Again, the best way to get confident doing this, making sure you're doing the right thing, go down to your clinical skills lab, go down to Resus, or book yourself onto a course and get some hands-on experience. Because you don't want the first time you're doing this to be on a real child. Now, we've been through our ABC. The next letter is obviously D, which stands for drugs. Before we can give the newborn baby some drugs, we need to get vascular access. So, imagine we've got a 27-week-old preemie that has just been born. Their wrist is about this thick. Do you reckon you can easily put a cannula in, as we've pictured here? Absolutely not. Particularly if they're shut down, requiring resuscitation. The likelihood of you putting a cannula in a pressurized situation is really, really, really unlikely. So that's not at all what we do in the emergency setting. What we would do is we would get umbilical venous access. Okay. So if we were doing this in a neonatal ITU or the neonatal ward, we would use a sterile technique when we do this. However, this is an emergency. So what we will do is we'll just use clean technique. So we'll have clean hands. We use things like sterile packets, but it's not vital that, we do every single thing with an aseptic, non-touch technique. We just want to get access as soon as possible so we can start to administer those drugs. Now, what I've put here is a diagram of an umbilical cord. So hopefully you can see that there are the 2 umbilical arteries and the one slightly larger umbilical vein below. The umbilical vein is the part that we would want to put a catheter or cannula into. But the way we would do that is we identify the vessels, so we know which vessel we're aiming for. We've got a scalpel. We cut about 1.5 centimeters away from the skin, so away from the belly button, a nice straight slice across, exposing those vessels. Once we're confident that we know which vessel is the umbilical vein, we'd insert our catheter and it's important we just keep pushing it in until we get a little bit of resistance. And then you need to aspirate some blood before using it. So you'd pull back with a syringe, get some blood, and run it through a blood gas machine. The reason that we have to do that is because, as you can see from my diagram, maybe with the labels on, you'd be confident saying which is the umbilical vein or the umbilical arteries. In real life, in an emergency, in that pressurized environment, mistakes do happen. And we really do not want to be trying to push in drugs into the arterial system. First of all, it's under pressure. Second of all, it also means it's not necessarily going to get to where we want it to go. Now, if we can't get umbilical venous access, intraosseous access is also a useful second option. I do not know how to get IO access. I understand the gist of, we crack out the IO kit, get a drill into one of the long bones, and put a catheter in there because the bones have a nice vascular supply. But I don't know how to do it, so I won't be explaining that this evening. Again, if that's something you're interested in, find someone that is trained in it and get them to hopefully explain it to you, maybe show you if you're in resus and there's a call out that requires IO access, but try and just seek out that practical experience. So we have vascular access, success. We now need to be thinking about what sort of drugs we want to give. And I know you're thinking there are loads and loads of different types of drugs, but in resuscitation of the newborn, we are only really looking at 4 different types of drugs, or maybe 5 if you want to be pedantic. But we would give adrenaline. So if the heart rate is below 60, despite us having been through all the stuff we've talked about this evening, we would give intravenous or intraosseous adrenaline, so not intramusculus. And then we would repeat that every 3 to 5 minutes while the heart rate is below 60. If, when we ran our blood glucose, we picked up some hypoglycemia, we would want to give some glucose. So normally some dextrose, again, intravenously. And it's definitely something you want to think about if they've been down for a long time, because that is more likely to cause hypoglycemia. The next 1 or 2, like I said, depending on if you want to be pedantic, is blood or fluids. So if you suspect that they have some sort of volume loss, or if they're in shock, if you think that they're bleeding, a bit like adults, we replace blood with blood. But if it's just that they are dehydrated and don't have enough volume, we would top them up with some crystalloid fluids. Could you please repeat the 5th drug? Of course. And then the last one is sodium bicarbonate. So this is if we have intracardiac acidosis, and sodium bicarbonate is just a base which neutralizes that acid. So the 5 drugs, not on screen, 5. So we have adrenaline, glucose, blood, crystalloid fluids, sodium bicarbonate. But you can kind of consider blood and fluids as kind of the same thing. Okay, so let's just do a quick recap. Here I've put on the European Resus Council's top 5 messages about newborn resuscitation. So these are all well-evidenced things and just things to bear in mind. So delayed cord clamping. We spoke about this at the start. That can optimize the condition, especially in preterm infants. So if we are able to delay the cord clamping, it allows them to continue to get those nutrients from the mother as it kind of progresses or transitions from one environment into the next. The second top message is that effective thermal care, so those woolly hats, those thermal mattresses, drying them off with towels or putting them in a plastic bag, is really, really important for a good outcome. As we've spoken before, fast heart rates will indicate adequate oxygenation, and it is probably the best sign in the newborn that they are receiving appropriate ventilation. We've said it several times this evening, but ventilation is the name of the game. So simple steps that we can do to support the airway and breathing will manage most issues. So once we're getting that kind of the appropriate ventilation, we should be okay. And as a result of this, chest compressions are only effective once ventilation is established. And if the heart rate is remaining very slow, that's when we'll be thinking about doing our chest compressions. So this was the scenario that we discussed during my training, and apparently this does happen, and several of the more experienced doctors said they have known it to happen in departments that they've worked in. So you'd be working in the emergency department, you've seen kind of a young lady in their 20s with some abdominal pain, maybe some PV bleeding, and they don't really know whether or not they could be pregnant. So you go off, you request your investigations. You're, of course, someone in abdominal pain, like I've written here. You'd be requesting a pregnancy test in any woman of childbearing age. But all of a sudden, the emergency buzzer goes off for that room. So you and various nurses, doctors in the area all go rushing in. But the nurse tells you that the patient has just given birth. No idea that she was pregnant, but the baby's now here, but it's not breathing. So you immediately shout for help. Make sure that some of your colleagues are looking after the mother who has just gone through childbirth, and we would go back to the start of our algorithm. So I think I've put the official algorithm on here, which is very small, and there's just a QR link there to a really good website a really good web page on the Resuscitation Council guidelines where they go and explain each step. But back to our scenario. So it's not breathing. So let's go all the way back. And the first thing we're going to do is make sure we're going to warm that baby. So we're going to say, please can we have some towels? Let's dry this baby. Let's stimulate them, see if we can get them breathing. Let's get rid of the damp towel. Let's wrap them up, put them on a thermal mattress, and let's get them into the resus bay. You start to assess the baby. It's floppy. It looks a bit pale. The breathing is kind of shallow, and it's working really hard, the baby. The heart rate is 65. And you think, well, this baby is in trouble. So we position our Airway. We also nurse to go and put out a paediatric cardiac arrest call. You ask one of your colleagues, to bring over the paediatric or neonatal crash trolley. We do our chin lift, or actually we said it was a floppy baby, didn't we? So we're probably going to be doing a jaw thrust or a jaw lift. I suppose it's slightly gentler in a baby. So we get that Airway in the correct position. We can't hear any added sounds. So we're quite happy that we have managed to, reposition our Airway in the correct way. We put on our face mask and we start our inflation breaths. So, as I'm sure you remember, we do our 1, 2, 3, 1, 2, 3. We do that 5 times, watching really, really carefully the chest to make sure that it is rising. And you know what? We've done a good job. We've got the chest rising. The heart rate is starting to come up. It's about 85 now. So given that it's still below 100, that might mean that our ventilation is not being as effective as we would like. So what we're going to do is we're going to repeat those 5 inflation breaths. So once again, 3 seconds, 1, 2, 3, 1, 2, 3 on the bag valve mask. And now we've got some extra colleagues, so we asked one of them to come and, provide a really good seal around the mask. And now the heart rate has gone up. We can see the chest moving. So we're happy that our ventilation is doing some good. So we're going to continue to ventilate. We're going to be doing 30 breaths a minute with 1 second inflation. So 1, 2, 1, 2. And after 30 seconds of this, we are going to reassess. So at this point, the heart rate has dipped again. So while it did come up, it's now dipped again and is sitting at about 70. We look at the SATs. It's been probably 4 or 5 minutes. And the SATs probe is showing that the baby is only saturating 60%. So we're going to have to start some chest compressions. So we asked one of our colleagues to come in. They've done their neonatal life support course, so they know exactly what they're doing. And we're going to be communicating between the two of us on the bag valve mask and then doing the chest compressions. So we get 3 chest compressions to every 1 ventilation. And the anaesthetist says, right, I think we should intubate this baby. So they start getting the kit ready, and we continue to resuscitate the child. As well as the anaesthetist, we also have a paediatrician who, for their sins, will have had, lots of experience covering the neonatal unit, the NICU. So they know how to get umbilical venous access, and you see that they take out their scalpel, they cut across, they have a look at the vessels, they thread that catheter into the umbilical cord, aspirate a blood sample, which someone kindly runs to the blood gas machine while the anaesthetist is obtaining access through intubation. And someone comes back and says, yeah, it's all good to use. It's a venous sample. And then we start, again, we reassess our baby. So heart rate is, it's staying at about 60. So we're going to give some adrenaline. We would, of course, look up the dose, although in the boxes for neonatal resuscitation, they do come pre-drawn up. So we give our first dose of this. We've had a look at our blood gas. They're not hypoglycemic. They're not acidotic. And we don't think they've lost any blood or fluids. So we continue. So I'm just checking the messages. We continue with our CPR and ventilation of the baby for another 30 seconds. And then we do another assessment. And now the heart rate has come up to 90. The saturations are coming up to 95%. And everything seems to be going in the right sort of direction. So, as I said before, this here is a really good resource. It explains a lot of the science far better than I can. It goes through every single step of our algorithm. And I've just seen that there is a question. So it says, this is from Jürgen. I hope I'm pronouncing your name correctly. So I can imagine that premature babies, the neck position isn't so easy to find out as to whether they're hyperextended. So, for example, below 30 weeks. So I must say, I have not stabilized the airway in practice of a premature baby. But absolutely, they're going to have less tone. They're going to be much smaller. So that is why we're reassessing things like the heart rate. We're looking to see if when we do our ventilation breaths or inflation breaths, the chest moves, and it's that we can use as feedback. So even if we think we're in the right position, we give those 5 breaths, the heart rate, it stays really low, the chest doesn't move. That tells us, actually, probably we're going to need to reassess, the seal of the mask, and actually that airway positioning is going to be one of the things that we reassess. So hopefully that answers your position. So I agree, yes, it's difficult, but that's why we use those kind of proxy measures to give us some feedback. Okay. And is there any other questions? So what I've done here is I've put a QR code that links to our feedback. For those of you that have attended our webinars before, you know that you'll be sent an email link to this as well. But basically, just take a couple minutes, write some feedback, as well as, for our presenters, it can go on our portfolios, but it also allows us to go and improve our teaching. It allows us to think about exactly what you guys need and want. So be honest, be direct, say exactly, tell us the things that you like, and we'll carry on doing that. But if there's something we can do to get better, we're always looking to improve our webinars. Any other questions coming in? I can see that Jürgen said, thanks. Good, glad I could answer your question. I'm just going to send the feedback out. Okay. And as you can see, a link has just popped up in the chat. So thank you very much for joining us. I know it's been quite some time since the Paediatric Series has been putting on webinars. But now that I'm working in an area where we see far more children and I have access to the ED doctors, the paediatric ED doctors as well as the ED doctors, I'm hoping we'll be putting on more regular webinars. Oh, so Mars is asking, do I know of any paediatric emergency courses offered in the UK, like paediatric trauma courses or paediatric emergency courses like Impact? So I know that the Research Council puts on very basic life support and advanced life support, and they have a neonatal version and a paediatric version. If you look into kind of pre-hospital medicine, There are and other kind of society-driven courses. There are lots of different ones out there. Best thing to do, have a quick Google, but also ask your colleagues. I find particularly when you start to branch out from kind of the main official courses, there are some fantastic things out there. And unfortunately, there is also some stuff that is just there to make money. So find out what other people have done. But what I will do is I will have a quick look. And if I can find anything that looks particularly interesting, I will post it on the Facebook page later. Okay, hopefully that answers your question, Mars. Any other questions before we go? Okay, thank you very much. Enjoy your evening, everyone. I've now got to go to a night shift. But hopefully in the next few weeks, like I said, we'll have maybe some minors cases. We might have some talks from paediatricians or emergency department doctors that focus on paediatrics. So keep your eyes peeled. Please do fill out our feedback form. And if there's anything specific that you want teaching on, again, make sure you write it down there. Thank you very much.